Here is our clinical roadmap for today. We'll be covering the mechanics of obstruction, the 4 cardinal symptoms, diagnostic detective work, general management and surgery, and finally, common causes and culprits. Let's get right into it.
Section 1. The mechanics of obstruction. Traffic jams versus dead batteries. To start things off, we really need to understand what actually causes the digestive system to just grind to a dangerous halt.
So there's a huge, critical difference between a dynamic blockage and an adynamic one. Think of a dynamic obstruction like a massive traffic jam. Your car runs perfectly, but there's a physical barricade in the road. Out of sheer frustration, what do? You honk your horn. Well, in the gut, this honking is hyperperistalsis. It's loud, hyperactive bowel sounds because the intestines are vigorously fighting to push contents past the block. But an adynamic obstruction? That's like having a dead battery on a completely empty road. There's no physical blockage at all, but the gut's motor has just died. It leaves the abdomen chillingly silent.
Moving to Section 2, the 4 cardinal symptoms. Recognizing the crisis. When a patient gets rushed through those ER doors, we are hunting for a very specific quartet of warning signs.
Now, you might be wondering about obstipation. Listen, there's a critical distinction between your everyday constipation and clinical obstipation. It is an absolute red flag. Constipation just means you haven't passed stool. Obstipation, it means the pipes are completely, 100% sealed off. Not even a single bubble of gas or flatus is getting through. When a patient reports that, the ER team goes on high alert immediately.
So what are the 4 signs? Colicky abdominal pain, abdominal distension, vomiting, and obstipation. And here's the really crucial part. The exact order they appear in gives us our first major clue about where the obstruction is hiding. Think about it. If the blockage is way up high in the digestive tract, near the stomach, the patient's going to experience early, severe vomiting, but they won't look super bloated right away. But if the blockage is distal, way down in the large colon, gas and fluid are backing up for miles. That means massive abdominal distension happens long before any vomiting ever kicks in.
All right, Section 3, diagnostic detective work. Solving the X-ray puzzle. Once we suspect a block, it is time to order the essential scans and really confirm our detective work.
We usually start by comparing erect and supine X-rays. The erect X-ray, taken while the patient is standing up, tells us if an obstruction is actually there. We look for more than 3 of these abnormal air fluid levels. But it doesn't tell us where it is. To find the actual site, we switch to a supine X-ray, with the patient lying flat. Here, we're looking at the specific visual patterns of the dilated bowel. If it looks like a stacked stepladder, boom, it's in the small intestine. But if we see these incomplete ridges, called hastrations along the edge of the film, that points straight to the large intestine.
And we've got a mathematical threshold for danger here, the 3-6-9 rule. This is absolutely crucial. It warns us that a small intestine over 3 centimeters, a large intestine over 6 centimeters, or a cecum over 9 centimeters is at imminent risk of perforation. It's a vital mental checklist for radiologists and surgeons. Once that cecum hits 9 centimeters across, it is stretched to its absolute breaking point. It could burst at literally any second, turning a contained emergency into a catastrophic infection.
While initial X-rays are the standard starting point, our ultimate imaging tools actually shift depending on whether our patient is an adult or a child. For adults, the absolute gold standard is the contrast-enhanced CT scan, or CECT. It gives us a crystal-clear 3D map of the blockage. But for kids, we really want to avoid unnecessary radiation. So the investigation of choice pivots to a highly skilled ultrasound. Section 4, general management and surgery. The ticking clock. We've made our diagnosis, and now we have to stabilize the patient before a potential strangulation turns lethal.
Let's dive into the rigorous protocol that every single intern has drilled into their head to decompress the bowel. Step 1, we blast them with IV Ringer's lactate to replace massive dehydration and fluid loss. Next is a nasogastric, or NG tube. Why? Well, that massive bloating we talked about is actually caused mostly by swallowed air. The NG tube acts like an exhaust pipe to decompress that pressure. Then we add broad-spectrum antibiotics and painkillers, and we watch. If they don't improve, it's a straight line to the operating room for an exploratory laparotomy.
Now, if we do have to open the abdomen, the surgeon uses a strict visual checklist to decide right on the spot if the bowel can be saved. First, they check the cecum, just to quickly confirm if it's a large or small bowel issue. Then they judge the tissue itself. A viable gut is a healthy pink. You can see the arteries pulsing, and it actually twitches when gently stroked. But if the bowel is a dusky black color, has zero pulse, and just lies there completely still, that tissue is dead from strangulation and it has to be surgically removed immediately.
And here is a crazy statistic for you. If a CT scan shows reduced bowel wall enhancement, that patient has an 11 times higher chance of deadly strangulation. That mandates immediate surgical intervention. This single detail from the radiologist can completely alter the surgical timeline. Basically, if the contrast dye isn't lighting up the bowel wall on the scan, it means blood flow has been choked off. You do not wait around to monitor this patient, you rush them straight to the OR.
Which brings us to Section 5, Common Causes and Culprits, the lineup. We've arrived at the final stage of our journey, identifying the specific diseases and structural anomalies causing this traffic jam.
Let's start with adhesions. These are fibrous bands of scar tissue, usually left over from past surgeries, and they are the #1 cause of bowel obstruction overall. But get this, they are the one major exception to the rule of immediate surgery. Unlike other dynamic obstructions where doctors rush to operate, adhesions are managed conservatively for 48 to 72 hours. Why? Because most of them actually resolve on their own with just IV fluids and an NG tube. Plus, cutting the scars, a procedure called adhesiolysis, can perversely cause the body to generate even more adhesions in the future. Kinda ironic, right?
Now let's talk pediatric emergencies, specifically newborns, where distinct visual bubble patterns dictate our surgical approach. We're looking for atresias. These are basically congenital dead ends in the bowel. If the block is in the duodenum, the X-ray shows this classic double bubble sign, one bubble for the stomach, one for the duodenum. If it's further down in the jejunum, you might see a triple bubble, or, incredibly, a coiled defect that looks exactly like a Christmas tree on the scan. These require precise surgical bypasses or resections to give the newborn a continuous, functioning digestive tract.
Then there's intussusception. This is wild. It happens when one part of the bowel physically swallows the segment next to it, basically telescoping inward. On a pediatric ultrasound, it literally looks like a donut or a target. But here's the really amazing part. A contrast enema that shows a claw sign isn't just diagnostic. The hydrostatic pressure of the fluid expanding inside the gut often forces the telescoped bowel to pop right back out into its normal position. It essentially cures the child without a single surgical incision.
Moving on to volvulus. These twisted bowel loops are incredibly dangerous, closed-loop obstructions. A volvulus is a catastrophic twist in the gut. The sigmoid volvulus is more common, showing up on an X-ray as a massive coffee bean shape pointing toward the right upper quadrant. Sometimes, doctors can actually explosively untwist this in the ER using a sigmoidoscope. A sickle volvulus, on the other hand, points to the left upper quadrant, is usually stuck fast, and almost always requires surgery. If either of these has ruptured, contaminating the abdomen, surgeons have to perform a rapid Hartmann's procedure. That means removing the dead segment, creating a temporary colostomy bag, and closing the distal end until the patient is healthy enough to be reconnected weeks later.
Next up is Meckel's diverticulum. This is a fascinating remnant of our embryonic development, basically a tiny pouch left over from the umbilical cord's connection to the gut. It mimics appendicitis, but it perfectly follows a mathematical rule of twos. Check this out. It occurs in exactly 2% of the population, it's about 2 inches long, and it's located exactly 2 feet away from the ileocecal valve. Because it often contains misplaced, acid-secreting stomach tissue, it can bleed really heavily in kids, or act as a pivot point for a massive bowel obstruction in adults. In fact, if a surgeon goes in for appendicitis and finds a perfectly normal appendix, their very next move is to run the bowel to hunt for a hidden, inflamed Meckel's pouch.
And then we have superior mesenteric artery, or SMA syndrome. This rare but dramatic condition shows how just losing an internal cushion of fat can trigger a massive mechanical obstruction. Also known as Wilkie's syndrome, it happens when rapid, severe weight loss, say from anorexia or being in a prolonged body cast, causes a specialized fat pad in your abdomen to dissolve. Without that fat acting as a cushion, the angle between the aorta and the SMA collapses like a pair of scissors, physically pinching the duodenum shut. To treat it, you have to start feeding the patient through an IV to rebuild that crucial fat pad and prop the artery back open.
So, as we wrap up this explainer, I want you to consider this. Knowing that finding even an asymptomatic Meckel's diverticulum with a narrow base requires removal to prevent future disaster, how does this level of surgical foresight change the way you view the immense detective work required in emergency medicine?
Think about it. From differentiating the honk of a dynamic bowel from the dead silence of an adynamic one to measuring those 369 thresholds, the path to saving a patient's life relies on brilliant, rapid deduction. So the next time you picture an ER doctor, don't just imagine a frantic room. Picture a master detective rapidly solving the most high-stakes, literal life-or-death puzzles inside the human body. Stay curious, keep learning, and I'll see you in the next explainer.